So, good afternoon, and OpenEHR and FHIR, competing or complementary standards. So I think this is a very, very big topic in all audiences, and I don't want to sort of keep you waiting, so please look at this picture. And I think that you can see that FHIR and OpenEHR are friends, so they look quite happy together, so to say. So my name is Hanna Pohjonen, and maybe I give you a little bit of background from the OpenEHR side so you understand why I am standing here. So I am recognized OpenEHR educator, so certified by OpenEHR International. I'm also co-chair OpenEHR Finland, and I lead OpenEHR International's education program. And then a little bit about Tallinn. So I'm also visiting lecturer in Tallinn University of Technology. And even in this room, there are a couple of ex-students of mine, and I suppose that some are also online. So my focus has always been data sharing and sharing of workflow. And today, my focus is open ecosystems. And when I say open ecosystems, it is not only about OpenEHR. It's also about FHIR, it is also about OMOP, and even IHE standard profiles. A couple of slides first about OpenEHR, because I think that maybe there are some people who have not heard about OpenEHR. So what is OpenEHR, OpenEHR? We simply say OpenEHR because it is easier to pronounce. It is a standard open source specifications, a set of specifications, a set of sort of recipes for storing, managing, retrieval, and exchange of health and social care data. So also social care data. And then these specifications, they are used to make data models and to make various software. And the software can be either open source or commercial. And there is also support for processes in OpenEHR. So we can, for example, turn guidelines and evidence-based guidelines and processes into applications, into computer understandable format. This is a so-called GDL2 specification. Okay, OpenEHR was originally built for persistence, for storing clinical data. And it was originally built for primary use. Today, it is also used for more detailed data exchange, and it is also used in secondary use, hand in hand with OMOP. So in the OpenEHR concept, data is stored using a semantically coherent, open international data model. That data model is vendor neutral, it is technology neutral, and it is even language neutral. And when applications produce data using OpenEHR, applications understand each other's data. And this is very, very important in healthcare. You remember 20 plus years ago, maybe some have been in the field already that time, we had a similar question in imaging industry. So we had Philips, Agfa, GE, etc. And they had their own vendor-specific data models for imaging objects. And then DICOM started to come into the picture as the harmonized data model. And today, DICOM is the de facto standard in imaging. So all bits and pieces in the imaging industry, they use this harmonized data model for producing imaging information. And we can plug and play. All bits and pieces can understand each other's data. This is the same that we try to do now for the electronic health record industry. And when applications produce data in a similar way, then we can separate the application layer from the data storage. In OpenEHR, we call that data storage OpenEHR Clinical Data Repository. And there's also a specification for searching data from that OpenEHR Clinical Data Repository, and that is called AQL, Archetype Query Language. And it allows very fine-grained content-based queries to the clinical data repository. I'm a big fan of AQL, I admit. In OpenEHR, we define clinical concepts and social care concepts in a maximal way. So this means that it is not only the data, it is also the context where that particular data was produced in. And then these models are governed by OpenEHR International. And I'm also very proud of the OpenEHR International Governance Program, where clinicians are heavily involved. This is an example archetype. So this is a body temperature archetype. And you can see here you have the actual data. And then on the left-hand side, you have some context information. So for example, environmental conditions or device, the measurement location, etc. So this archetype structure puts the data into a context. And it is a lot easier to agree on a maximal content than minimal content. And this is what OpenEHR is doing. So we represent data in these kind of maximal clinical concepts or social care concepts, and we call them archetypes. We have 3 levels in our modeling layers. So first of all, we have the reference model. And that's the techie part, all bits and pieces, Lego bricks, archetype classes, data types, etc., that we then use on the archetype level when we build these clinical concepts. And those clinical concepts or archetypes, they are governed by the OpenEHR International. And we really focus on those so that we only localize very, very minimally. So 90%, for example, in Norway, they calculated this, 90% of the archetypes you can use straight away from the international library. And then we have the template level. And the template level is for application development, it is for building document schemas, it is for building FHIR messages. So on the template level, we think that, hey, what kind of data do we need? And then we gather those data points from different archetypes that we want to use in this particular local use case. So we reuse data on the template level. What is then an open platform? That is very, very essential. And it is essential also to understand the relationship of FHIR and OpenEHR. So open platform, the most important service on the open platform is the clinical data repository where we store data. But then we have a bunch of different other shared services that the application level can use. And the open platform supports many different open standards. It's not only OpenEHR, it's also FHIR, OMOP, etc. And then those services can be used via those API calls. The open platform actually offers a new way forward. So instead of these one vendor bundles or monoliths, we can build a modular EHR. We can build a multi-vendor ecosystem. We can really boost also involvement of little companies having niche functionalities. And you can see in this picture, we have this open platform. Underneath, we have the repository, we have the shared services, and then these health and social care functionalities, they are then interacting with OpenEHR, with FHIR, towards this open platform. So EHR is split into functionalities. And also the care delivery entities can build some of these functionalities if they want. And what is important is that also legacy plays a role. This is a stepwise journey. So you can also integrate legacy to the platform, and this is what we are doing in different OpenEHR-based projects around Europe. What should we pick? Should we pick up OpenEHR? Should we take FHIR? I think we shouldn't even discuss this, because we should always look at what standard fits for a particular use. So we should use them together. And when we look at different standards, let us take FHIR first. So the purpose of FHIR is data exchange, like Graham explained, between IT systems with various internal data models. And when we use FHIR, these internal data models stay the same. It covers the most common parts of data and some medical subdomains. We talk about this 80-20 rule for modeling. It is intended for exchange of high-value, common or aggregated data items, but not full EHR data. And it is not intended, originally at least, for long-term data storage, nor as the foundation for EHR. And Graham already talked about resources and profiles, so I don't go into them. It's very developer-friendly, really friendly. And it's also very advanced in demographic data models. But you look at this heart. I made this heart because I wanted to show to you that we all fit together. There is Graham, there is me, there is Sulev, everybody. Okay, and then about OpenEHR. It's data persistence, that is the main purpose, in a semantically coherent format and also exchange. But when we exchange more detailed data, then OpenEHR comes into the picture. Otherwise, we count on Graham. And the goal is to harmonize all clinical and social care concepts and define them in a detailed way. OpenEHR data repository is a key element, so long-term persistence of data is important, and also searching of data on the individual level, but also on the population level. So the archetypes are internationally covered. This is very, very important to understand. And then we only reuse them, the same archetypes, on the local level. And we can use them for primary use, secondary use, and other analytics use cases. But OpenEHR may be a little bit complex to start with. I agree that we should learn more about the FHIR community in that. And also, we rely on FHIR in demographic use cases. We have also demographic archetypes, but I think FHIR is a lot better in that. And then I would like to take one thing, like highlight one. OpenEHR is clinically led. And this has been like a wow effect to me, because I work very heavily with clinicians, and I think this is really, really important thing. This is not IT-led design. This is clinician-led design. Okay, we have OpenEHR, we have FHIR, we are friends, but how can we then work together? We also need mappings in between. And in an open ecosystem, FHIR-based apps, they should be able to store and query data from the OpenEHR clinical data repository. And now I'm happy to tell you that look at this link there. You can find open source mappings between FHIR, between OpenEHR and FHIR, and vice versa. And also an OpenEHR engine, mapping engine, to really make this concrete. I'm so happy about this. This is like recent news from this spring. Okay, about my wow effect. So I wanted to take this separately. So OpenEHR is clinically led, and I would say that it's the first time in the history of EHR that I can say that, hey, this is clinically led. So this means that clinical professionals, they have made the data model. They know how the data should be structured. They know what is important to know about the context. IT-led development is over. We need to get the clinicians along with the IT guys. CKM, International CKM, is the tool for commenting and reviewing archetypes, but also publishing and managing archetypes. So the CKM is the central element in the governance of OpenEHR. We have over 1,400 clinical professionals from different countries who have been building the data model, and then a bunch of different other professionals. And the doctors, they say to me that it is easy to understand the OpenEHR data model. So if you look at this body temperature, for example, it's visual, they understand it. So they are for it. Also, the application development can be clinically led. And in many places, it is already clinically led. Because in OpenEHR, everything is about the data, and clinicians understand the data. So the whole development starts thinking, aha, what kind of data do I need? It's model-based, data-based user interface design. We have co-development programs, sandboxes, hackathons. Care regions make their own applications as well. And I think that the applications are more likely to be successful when we have the clinicians sitting side by side with the IT guys. I wanted to show this to you. I was in the Nordic Hackathon for interoperability mid-March in Stockholm. And our focus was a multi-sig patient Arne. We had 87 software developers, 2 open platforms, one from Campio, one from TietoEVRY. And then the application builders, they made applications for Arne using FHIR and OpenEHR. My role was to educate and to help these application vendors to make templates that were under the application development. And we had a lot of clinicians there and other clinical professionals, also social care professionals, sitting with the software developers to make it happen. This is one example of an open platform. It is Stockholm region, so they bought an OpenEHR data repository, and then now they are building the applications on top. They just bought the core journal, and they are going to make other applications, and all interactions, you see the guys there, OpenEHR and FHIR. In Finland, OpenEHR modeling is under HL7 Association, and here you see the FHIR ambassador of Finland together with me, and we look quite happy, I think. A couple of glasses of wine before, but that's okay. And I was talking to the co-chairs of OpenEHR modeling group in Finland, and if Estonia goes for OpenEHR, you are so welcome to collaborate with us. Very, very welcome. So all our OpenEHR implementation guides are in English, so that should not be a problem. It takes two to tango. And on the international level, OpenEHR International and HL7 International are already collaborating. Graham and Rachel, the CEO of OpenEHR International, are sitting there quite closely, you see, on the sofa. Yeah. And then next week, Graham already told about this happening in Amsterdam to make it really closer to practical user scenarios. Also check this publication. It has been published. The writers, Graham is one of them, Rachel is one of them. They talk about the complementary standards. Okay, what I think is the future? I think that in the future we should and we will have an application e-marketplace. And from that e-marketplace, we can pick and choose the right OpenEHR-based applications to our own ecosystem. And of course, the use scenarios are different. We have GP practices, we have hospitals, etc. We need different applications. And what is important is that we can also have some niche applications there. We can have competing applications there. So really the competitiveness of the market is there. So portable applications, also across borders. And I think for Estonia, I'm really, really hoping that you go for it, because it's important for your small vendors. Small vendors are close to my heart, so that it makes it easier for them to go international. Data can be located on various open platforms. We can have a federated data architecture. And we can add data from various sources. Also patient-reported data. This is something that Finland has been a forerunner in OpenEHR modeling. So we have made templates. Also, they were used in the hackathon for example, patient-reported measurements data. And then open standards. All of these three open standards. Sule will talk about the OMOP very soon. But there's also OpenEHR OMOP, open source mapping available. So we really welcome OMOP as well. So this is the future. And it's not only future because, for example, in Catalonia, they are building this kind of a e-marketplace, and they are asking for applications to come, certify, and stay in this e-marketplace so that people can pick and choose. So for Catalonia, it happens already. And what I would like to see a Nordic Baltic e-marketplace. So I think we are sort of one economic area. Why can't we work it together? Why can't we show to Europe that we can do even more than European health data space is requiring? That's the minimum. So we should be more ambitious and really go for it. 4.5 minutes left.
Thank you. Perfect. So, any questions? Oh, I can see a hand.
Thank you so much for a very good and very informative presentation, first of all. I am Kertti Merimaa from Nortal, and we...
Nice to meet you.
We've been writing to each other. So, and I act as a vendor for the hospitals. We have been working with the hospitals hand in hand for nearly 20 years now. And following from this experience with the hospitals, I do have one question about your very intriguing vision for the future of having this open marketplace for these smaller scoped apps, which in general make a lot of sense. But how would you tackle the fatigue from the end users to have abundance of different apps to do different kinds of pieces and parts of the work? What we see, at least in our hospitals, is that every hospital today, the bigger they are, the more information systems they have in use. So it's not just one big clinical information system, the monolith, as you would say. It's usually one bigger system that acts as a heart, and then there's a bunch of like integrated systems that are performed. But one of the feedbacks that we get from our users is that they get very tired of the abundance of different systems and different solutions, different front ends. So how would you tackle this fatigue?
Yeah. A wonderful question. And if we go back to Karolinska, for example, and the region Stockholm, they bought a quite small core system, but they made it sure that it's also OpenEHR based and also, it is modular inside that core system. And then they are going to have different applications. But what is important so that they don't get tired because they have all these different niche applications is to provide a unified user experience. And it is really, really important that we have one dashboard where we have these different applications, even if they come from different vendors. Because I can totally understand that if you have, tens of different applications, gradually you slow down with them. So it has to be like one unified experience. A good question, really.
That's exactly where I was aiming towards too. So we're actually talking about a lot of granulated back-end applications rather than granulated front-end applications in the clinical setting.
It's actually, I would say that we have the data platform back-end. Then we have the front-end applications, but you embed them in the unified user experience. And I have a couple of examples to you that we can discuss later on, because this is what the clinicians want. They want modularity, but they want uniformity. And we have to give both.
That's what it is. If I may have another question. So this is very 101. To like all these kind of standards and terminologies that bring value to the health sector, they only bring value when they are implemented regionally, because these standards are all about connecting organizations, connecting people, connecting information, right? So it has to be implemented regionally. So my question is, in your experience, could you give us like ABC for the government agencies to take into consideration if they have this ambition to actually adopt like a platform or a standard like OpenEHR? Because data exchange, it's a little bit different. The FHIR implementation would be a little bit different, but localization of OpenEHR and how would that work, just so that we would all be on the same.
I'm laughing because actually in the Nordic countries, the governments have not been involved. So this has been very, very vendor-driven. So the vendors, they have started to utilize OpenEHR as their own internal data models. So very, very vendor-driven. And only now, I think in 2 years' time backwards, also the healthcare delivery entities start asking for OpenEHR. So we had, I'm so proud of them, these Nordic vendors who saw the future and took OpenEHR there. But I hope that Estonia makes it in a different way. Of course, I hope that the vendors will start adopting OpenEHR also in Estonia, but I would also like to see the governmental support. And if we think about the steps, I think it is important to have a stepwise journey. So first of all, make the decision to separate the applications from the data. Make the decision, make the data strategy. Also, of course, you have your e-health strategy, but the data strategy. And then you start storing to that data platform. Then you can have legacy integrated to the platform, but you can have enriching other applications also, even if the legacy stays there. Or you can start taking functionality after functionality from the legacy and turn it into OpenEHR. And at the same time, invite your wonderful new small applications to work on the data. So AI applications and other niche applications. And then I would also at the same time like to see the governmental support for the data modeling. But the data modeling part is not so extensive because you can use the data models from the International Library. It's more like use cases, for example, for the companies when they start building their applications. Maybe this helped a little bit, but a lot more steps, but I think that we are done.
Thank you. I hate to cut this discussion, but we're continuing. Yes, thank you.